Hello and welcome to the Neurocritical Care Society podcast. I'm your host, Dr. Nick Morris. Before we begin, please note that the views and opinions expressed in this podcast are solely those of the host and guests and do not necessarily reflect the official opinions or positions of the Neurocritical Care Society. All right, having gotten that verbiage out of the way, I'm really excited today to welcome our guest, Dr. Theresa Human. Dr. Human is a critical care pharmacist who got her start in critical care pharmacy at the University of Virginia. She was most recently working clinically at WashU and then made the transition to the pharmaceutical industry, and she currently holds a position at Cumberland Pharmaceuticals. She has been an incredible advocate, supporter, and stalwart of neurocritical care and the Neurocritical Care Society. She's served on the board of directors. She's on the board of trustees for the Neurocritical Care Foundation, and she has been an integral part of the Curing Coma Campaign. Dr. Human, thanks so much for joining us.
Thank you for inviting me.
All right. Well, let's just kind of get right into it. What brought you to this weird field that we're in, and how did you end up within the critical care pharmacy space in particular?
It's a great question. So it was a very twisted sort of path. I went to pharmacy school thinking that I wanted to do, at first it was like, oh, I'm just going to count pills and be in that retail space. And then I really thought, oh, now I really like the research aspect. So then I thought I was going to go work for like a Pfizer and do R&D kind of things. And then there was a pharmacist who was in the MICU at WashU. Her name was Robin Schaaf. And she came and taught one of our therapeutics classes and had some of that sepsis and all that hemodynamic monitoring. And man, that moment to moment, things changing and having to alter what you're doing based on real-time information was really exciting to me. So I then sort of shifted over into wanting to be more clinical, really love being in the ICU. So did my residencies. As I got into the critical care residency at Medical University of South Carolina, they really want you to look at every different ICU type, right? So you have the medicine ICU, the surgery, the ERs, and I got into the neuro space. And what I loved about it is the autonomy that the neurointensivist as well as the pharmacists in those spaces have, because the surgeons want to be in the OR and we know so little about it. So it's not cookbook, right? You're not just an algorithm doesn't just pop out. Everybody's different. We don't know crap about neuro, right? We're just making it up as we go. Everyone is excluded from all the big trials. So you basically have to take all of this information and all this data that's out there and sort of put it into your own brain, into that own patient and whatever's going on with them, and come up with what you think the best solution is. And that to me was so thrilling. So then after my critical care space years at UVA, then I worked initially with Dr. Tom Bleck, who is a legend in his own. And so he really got me thinking in a new way, right? Then like, how do we start this research and what makes this better for the patients? Because again, and I think we'll talk about curing coma in just a little bit, but that's really, I think, the crux of where curing coma can come in, is because everybody's doing this little bit of research here, this little bit of research here. Oh, we do a case series here. We do a something here. That was when the intensive glucose stuff came out in the more medicine and surgical populations, of which then everybody thought, oh, we need to be doing this. And that's when you step back and you're like, but is this right for my patient, right? Is having too many low glucoses beneficial or more harmful for these patients who need the glucose for their brain injuries, right? And to recover. So that's what's exciting about neuro, and that we're right on the cusp of, I'm really hoping to pull people together, both community and clinicians, to be able to do bigger research, to do better outcomes, or to have better outcomes in our patients.
Yeah, I totally agree. That's a really interesting perspective. The idea that we have more autonomy because we, in some ways, have less data. And it is fun, right? It is fun to like pull from these different sort of related fields and evaluate the data in the context of our patients and see whether we want to follow that data or not. And you're right. I think in many ways, it's been a criticism of some of the NCS guidelines that they end up saying a lot like, well, we don't know, but it's the truth, right? We don't know.
And I sat as the co-chair for the guidelines committee 2 years ago, I guess. And you're absolutely right. There is very little data. And if you follow the grade criteria, you really shouldn't be making, we recommend this based on opinion, although we were having to shift to some of that because there is no data. So we actually have a guideline that basically has no recommendations because there is no data, right? Yeah. So what I do hope, though, is leadership and people with money and grants and scholarships, I hope they do look at these guidelines and say, oh, we should probably put some money into this space because they had 12 PICOs with no suggestion for the boots on the ground neurointensivist or neurosurgeon. So
yeah. No, I think that's interesting. It wasn't my intention to talk to you a lot about that today, but I'm wondering, now that we brought it up, do you think do the grade criteria, I mean, should we be using them right now, like in our guidelines, or should we even be writing guidelines? Should we just write these like scientific statements where we can kind of get away with consensus, 10 out of 12 neurocritical care people agree that we should do this? What should we do?
Oh, Nick, that's a great question. And I think if you went to the board of directors and to leadership in the NCS space, you're going to get a different answer. So the first guidelines that we wrote, and the first ones were the status epilepticus guidelines that were chaired by Gretchen Brophy. They were PICOs, and it was sort of in a PICO situation, as well as the subarachnoid hemorrhage guidelines. Well, actually, the subarachnoid hemorrhage were first, right? Aneurysmal. And it was more of a consensus statement, but it was written very similarly to the way a grade wants you to do. So we really needed to firm it up, though, right? We really needed to create some kind of criteria with which we're looking at all of the data and coming up with a suggestion. And grade is rigorous. It is a lot of work. It's time consuming, but it's an already validated process, right? We could do some of the other ones that are a little less critical and maybe come up with a little bit more guidance for those people who really use the guidelines to help them, right? These are the smaller, non-academic, even some of the academic centers, right?
We're constantly, right, like full, and we're putting borders in other ICUs where, but we're not there. And so these teams are left, and I get calls all the time like, hey, we have this small ICH that you guys said would be no problem to manage in our surgical ICU because you're all full, but we don't really know what to do here. And we were looking at the guidelines, and
they don't help us either.
No, exactly.
And then you still have big randomized trials for an ICH looking at blood pressure, and we still don't know what to do. Right?
Absolutely.
Right. So I think that the guidelines, so to go back to your original question, should be doing sort of white papers, recommendations, like whatever. I think at this moment, we really need a rigorous pathway or process for them. But I do think, and this is what Krishna and I were trying to do sort of at the end of our tenure of co-chair, was, okay, maybe we can say, yes, there is not enough data to make a recommendation based on grade. However, a best practice statement, right? And then that can guide people, like saying, we don't really know what to do with the blood pressure in this ICH, right? Or we don't know what to do with this patient who's been in status and has tried 3 drugs. But this is what a reasonable person would do that has taken care of these people. So we were really kind of trying to push for that. But again, there's so many different personalities and different beliefs in what a guideline should look like. Then you get some pushback. Oh, we're not doing good practice statements. Or then the whole thing is good practice statements. And then is that really a good guideline? So, I think you could talk about that, I think, for 45 minutes itself.
Yeah, no, it's really a conundrum, but I think the biggest takeaway for many of us is like, well, it's just up to us to actually get better evidence out there, right? I mean, that's the bottom line, is we have to do better.
And we really should be working together, right? Yeah. Because even though, like, if somebody came to your world and hung out with you for, I don't know, a year, You would think aneurysmal subarachnoid hemorrhages happen every day to everybody, 10 times, and because we see it all the time. But it's really very uncommon, right, across the population. So it would be really difficult for one center to do a study on aneurysmal subarachnoid hemorrhage and get the data that they need, right? These case series aren't helpful. So we really need to have some governing body that says, this is what we're going to do. This is how we're going to stratify people. This is how we're going to enroll people. Everybody's milieu is a little different too, right? Especially with the brain. And we don't know that much about the brain. And there's all these surgical procedures and these interventional procedures. So you kind of almost have to standardize all of that so then you can answer the one question, right? So I think working together is the best thing that we can do, both in this hemisphere as well as internationally. Again, because there's so many difference in different types of individuals, as well as their ethnicities, as well as all male, female, and then trying to take this already small group of people with this very rare condition and then trying to figure out what the best avenue is, I think is difficult, but working together, I think, is the best way to do it.
Yeah, I agree. I've really been impressed with some of our critical care colleagues that are running these very pragmatic effectiveness trials, and that have been coming out in big journals, New England Journal, JAMA. A lot of that is headed by people at Vanderbilt, looking at just things we do all the time, right? Ketamine versus etomidate for induction, for intubation. Should you bag someone after you give induction agents or not? Like, these are very common things, and they've shown
Absolutely.
that you can do this. And we have a lot of common things that we just haven't gotten the buy-in to collaborate on across large groups, that we could answer some of these, I think, conundrums if we just work together a little bit better. And I'm hoping maybe that the Curing Coma campaign is a way we can do that.
And I honestly think that that was sort of the moonshot, right? Like that was what everyone was calling it, Claude and Daiwai, whenever they had this vision. And I think a lot of that is there's a whole pillar, right, in the Curing Coma campaign where it's data collection. And then once we get all this data together, then we can go through it and mine it, right? If we have good data in our patient populations, then we can do a really good retrospective analysis and really look at that. And then it helps us then with the next pillar, which is then how do we go about doing the next prospective data, and hopefully then start working with legislation and NIH and all of these bodies who have a little bit of money so that they can dog ear some money for those spaces when we have a group of people saying we're willing to do the research together.
Yeah.
Or a large group. So I do think Curing Coma will really help that.
Great. I wanted to talk a little bit about sort of the role of pharmacists in neurocritical care. And you certainly spearheaded that. And I really noticed there's been sort of an emerging kind of force from the pharmacy group that's really cool to see. And so from your perspective, I guess, how do you see that critical care pharmacists are really impacting neurocritical care? And like, what are they bringing to these conversations about guidelines and curing coma? And why is it important we have pharmacists included in these conversations? Because from my own experience, it's very, very important. But I'm wondering from your perspective how you can articulate that.
Great question. Of course, I am a pharmacy advocate based on my background, but physicians, nurses, pharmacists, as a clinical team, all have a different lens that they're looking through when they're looking at the patient, right? So those lenses, though, need to, I think, all come together. And the lens that the pharmacist, I think, is looking through, obviously, is very therapeutic, is very genomic, pharmacy-driven medications based on what is happening to the body, right? And I do think that critical care, neurocritical care specific pharmacists, one, we have to understand the receptor and we have to understand what's happening in the body pathophysiologically, because there's no data to tell us this drug is going to work this way in this patient population. So we kind of have to understand, then we teach that, right? So one, we're looking at it from this lens. Secondly, though, I think pharmacists are great teachers. And so going on rounds, teaching the babies, the residents, the fellows, new attendings, learning back from them as well and absorbing that and putting that into your practice is amazing. And I think if you asked any of my fellows in the past if they liked having a pharmacist, I think they would say, where's Theresa? Why wasn't she on rounds today? Right? If I wasn't able to be there. Because I do think it's a team approach, right? But lastly, and specifically at UVA and at WashU, and other people have different practices, but the pharmacist is the one continuous person that is always there, right? The teams change, the residents change, the attendings change, but the pharmacist is the one person that saw that patient who's been there for 3 months, almost every single day for 3 months. So we know the history, we know what's happened, and we can pass that on along to the team. So we're sort of that underpinning that everything sort of sits on as well. And then I think we're also doers. Pharmacists are doers. You tell us what needs to be done, or we identify an area of weakness or something that needs to be done, and we're just going to do it, right? We're not asking for more money. We're not asking for more whatever recognition. We're just doers by nature, right? Which is why I think when you look at guidelines, and I'm not saying physicians are doers either, but pharmacists are definitely, they get it done. And so looking at the guidelines, a lot of times it's the pharmacists that are pulling these things together and making them happen. So I think all of those things, I think it's our lens that we see the patient through. I think it's that we're really good at articulating and teaching. We're also good learners and good doers. So, and I think we want the best for the patients.
Yeah. I've really been impressed. We have really an amazing pharmacist that rounds with us, Mike Armaheiser at University of Maryland. And I think of Mike sort of as like our ongoing like phase 4 post-marketing surveillance, because he is that constant presence, and like he picks up on these things that we just can't see as we come on and off service, right? Because he's always there. And so he's like, gosh, we decided we were going to start doing this, and here's what I'm seeing, right? And this keeps happening because we changed our practice back in March. And it's like, oh, really? I hadn't noticed that. And so I think that continuity piece that you mentioned is really sometimes overlooked. I'm wondering, where do you think pharmacists are still underutilized in neurocritical care?
Everywhere. Like, yeah, I think, yes, I think that
what's holding us back? Why everywhere? I mean, it seems you and I agree that they're just integral parts of the team. Why don't we use them more, and why aren't there more of them available?
So I think people don't, in pharmacy school, for example, there's very little taught on neuro. We might have a few lectures on, we don't even have it necessarily on seizures. We might a little bit, but we'll have like all the AEDs, right? Mm-hmm. But that doesn't help, put that into play, right? How do you treat a seizure? What kind of seizure gets treated with what type of agent, right? We don't really learn that in school. We don't learn about subarachnoid hemorrhage. We don't learn about insert parenchymal hemorrhages. We don't learn about, so all the things that we do in Neuro ICU, we haven't learned it in school. So you only find out about it if you want to do critical care, and if you go to a residency that has a neuro dedicated space, right? Then you're like, you either love it or hate it. And then you go into it, right? So I think it's just, we're figuring out how to even socialize it among pharmacists, that it's even a thing to do, right? I think that's the first piece. So there are a few of us in that space, because I think we just don't tell everyone that it's even an available thing. And then just underusing us. I don't know that we're underused. I think we're probably used as much as we possibly can. We just don't have the bandwidth to do anymore. Mm-hmm. So if we had more people, I think we would be more successful having pharmacists be used more. We're just overworked as it is. So bring us more pharmacists into the space, and then we'll rule the world.
You mentioned being overworked, and I worry about that, because you mentioned that continuity piece, right? The other side of that is that it's like you never get to take a day off where you don't have to be like hyper vigilant over some reaction or some drug interaction that you may have missed. Like, how, I imagine that's really hard.
Yes. So from UVA to WashU, I don't think I mean, we would have a day off or we have the weekends or whatever. But I was 100% always available. Middle of the night, if something came up and they really didn't know, or it was a real question, or what should, call me. Because again, it's about the patient, right? And there's only one of me, or there was only one of me for a long time. So I was always available on vacation, on weekends, on evenings. So yes, burnout, I think definitely is a factor. I also think burnout just in this space, whether it's a physician, a pharmacist, a nurse, a patient tech. I think burnout is a huge thing anyway. We know that because almost every patient we take care of, it's an unexpected injury. Families aren't ready for it. You have some where they have a tumor and it's going to be resected or, something like that, but it's usually an unexpected injury. It's very stressful. It's almost always life-threatening. We do see a lot of death, right? We do a lot of withdrawal of care because we don't really understand prognosis, which I know that Suzanne Muschlegel did a great job trying to start this prognostication for each of these disease states, right? And help us give better hope or not, whichever way, to the families. But all of that, I think, is taxing and weighing on us day after day after day, right? And then it's a lot of social work too, because now you're counseling families about what's going on with their loved ones, and you're doing the best that you can. They're doing the best that they can. Now they're away from work. Their, loved one is probably going to die. So I think it's all of those things. I think it's just a very high stress, high risk place where we're making the best decisions. There's no cookbook medicine here that we can. And so I think burnout is real for everyone in this space.
I wonder if many people who are part of the interprofessional rounding team really know what a day is like for the pharmacist. It seems like, you all kind of come in on rounds, you're there, you give incredible advice or point out where we may be harming a patient. And then, maybe you're gone, but I know because I talked to my pharmacist that because he's not immediately present on the unit doesn't mean that he doesn't have a million other responsibilities to do, or he's not spending a lot of time doing other work. So what does a day look like for the pharmacist? Like, do you like roll into the hospital and go right to rounds? Is there a lot of prep work for rounds? What are you doing after?
So yes, when you're a baby pharmacist, I would think just like any physician as well, right? When you're young and you're just learning, prep is just like you should look at all of your patients before you show up on rounds. It's not discovery rounds when you're young. But as you get a little more experienced, you can just listen to the resident, tell me what happened last night, and I already got it, right? And I can look at the labs really quick. So I would say, yes, prep work was initially a big part of my day before rounds. As I got old, and it just really became more, I just got to work and went straight to rounds for the most part, unless there was somebody that I needed to just follow up on for something specific. But then after rounds, you've got writing book chapters, where doing research, you're following up on your patients if it's a prospective study. You're going to, you probably sit on an IRB committee or two. You also sit on a neurocritical care committee. You're writing guidelines. You're still answering questions that is happening in the unit, right, at the same time. Or the nurse is running down to get you because something is happening and they need another boots on the ground, or they've got a malignant hyperthermia coming in from the OR and you need to be there, like whatever. So you're still managing all of this while you're still being asked to co-chair one of the, the one part of the Curing Coma, be the co-chair of guidelines, be on 500 committees at the hospital. You're on the critical care committee. You might be on stewardship committee for this, that, and the other. You're on mobility. You're on like all of this. Then they're like, oh yeah, can you write an on-call chapter for status epilepticus? Oh yeah, in my free time. Yeah, I'll do that. Oh, can you write a chapter for what up? Like, and you want to be a part of all of this. So you just make it work, which is why I also say we're doers, because very rarely did I say no. And then once I got a little further into my career, I would bring in junior individuals, like one of the pharmacists that worked with me who did residency with us and then stayed on. Her name was Lauren Sutton. So I would bring her in to learn that, but then I could guide her, right? So yeah, that's a day in the life. And then you go home and you cook dinner and you do laundry and you get a call from the fellow and then you put the kids to bed and then you get a call from the attendee. Why did you tell the fellow to do this? And then you, yeah, that's the day in the life.
Got it. Got it. And then, you mentioned burnout a little bit, and then we talked about sort of all the different directions you're pulled in and kind of the vigilance that's necessary and the lack of time off. Is there a story that kind of encapsulates some of the things that really make things hard? And people talk about this idea of like moral injury, right? Where it's beyond burnout. It's like where we're in situations often where we just know we're not able to do the best for our patients. And it seems like maybe these are the things that really lead people to want to leave the field or to really struggle. And I'm wondering if you have a personal experience where you feel comfortable sharing, where you've had, this kind of moral injury as a critical care pharmacist.
Yeah, I probably have a million. Probably, I hate to bring COVID into this at all, but I am not COVID, not necessarily because I mean, that's burnout on top of it, right? Like,
Sure.
so, but it was during this time where the families could not visit their loved ones, right? So here I've been working for 20 years.
Yeah.
You have the loved ones that are at the bedside and they can see how sick they are, right? They can see that they are dying from the inside out and that their loved one is never going to be the same again. They can see it. I would say the majority of family members, right? So you can, in those situations, tell the family members there's nothing more that we can do. And it almost makes you feel a little better, like to have those communications. But then what happened during COVID is that the family members couldn't be there. They couldn't be in the unit to see how sick. And there's no amount of FaceTime on an iPad that can show the loved one what that looks like in real life, right? So that's what you're trying to do to tell them how sick they are. Then you're having the conversation with them saying, there's nothing more I can do. And we literally were doing everything above and beyond, things that we would have never done pre-COVID, right? Because the families would have been like, don't do that. Don't do that to my loved one, right? Like, which is why when you code a patient, they want the family members in there, right? They want you to be a part of them, to be a part of it. So they can say, yes, keep going, or my loved one would never want this, right? We were doing all this coding, so to speak, or all this stuff to the patients that I know that the families would never have wanted. But yet they can't see it. They can't see how sick they are. That is the most helpless feeling in the world, that you're doing something to someone that is never going to work out well for anyone. And that is very wearing and taxing, I think that's probably the most recent scenarios. And that's just in a group of patients. That's not just one, and then there's always, I'll give you another example. Young kid, he was 23, comes in, was in the military, started having seizures when he was abroad. They brought him back they were from somewhere else out of St. Louis, bring him in. He was in status by the time we had got him. And that he was probably 2 weeks at that point, maybe 10 days. Mm. And you only have so many drugs. You only can put somebody in a pentabarb coma so many times, or hypothermia, or add so many drugs, or try different combinations and whatnot. And it gets to the point where you're like, I don't have anything left to give you, right? Yeah. And then you start second guessing yourself, because we kind of made up what we did during the time. We took the best knowledge that we had and made these choices. But then you're like, well, crap, what if I would have done hypothermia first? Or crap, what if I would have done propofol first? Oh, crap, what if I would have done, whatever. You then start second guessing, and then they pass away. And you're like, I just worked 3 months on this one person. Maybe I didn't do the best by him. Maybe I did the best by him. Yeah. So it's wearing.
Yeah. No, those cases are so challenging for us all, because we know some of them can get better, right? And so we keep hope months in, and then sometimes it doesn't work out, and that's devastating. We put so much into these, at that point, like really longitudinal relationships with families, and you get to.
I'm just still friends with the mom and dad, still to this day.
Yeah, it's way harder when you get to know them so well and they're not, it's not like the day of they come in with a devastating injury and we're kind of done. Yeah. All right. Well, maybe we can sort of change tracks here a little bit. And I'm wondering about your transition into the pharmaceutical industry. And I mean, we've talked about burnout. Maybe I'm being presumptuous by thinking that burnout had something to do with that. But
Not
what drove?
presumptuous at all.
So maybe you can talk a little bit about how you made that decision and what it's been like for you.
So again, not to belabor COVID because no one wants to talk about that, but that was, and leaning up to that, I would say I was already starting to have this, what we would call burnout or just exhaustion before COVID. And that was just icing on the cake. But some of it is also a change in the way, how do I say this? Leadership, the way that the leadership views patients, right? We're supposed to be a very patient-centric career choice, right? This is what we're supposed to be doing. But leadership at the top of a lot of these academic institutions, it's not patient-centric anymore. Now it's about the money. It's about how the institution can make more money, even if that means not allowing the right drugs or the best resources, not allowing enough resources, right? Not enough.
Yeah. Why are we still caring for this status epilepticus patient who's been here for 3 months, right? They're not going anywhere. Why are you doing this?
And if I need more nurses because I have 3 1-to-1s, right? And I can't get 3 more nurses because there's some kind of shortage or hiring freeze or because they're over budget or like all of those things that start at the top really lay down on us at the bottom that are taking care of the patients because we're not being supported like we used to. There's been a change. There really has been a change over the last 20 to 25 years where I used to feel really supported in everything I did. I felt like if I needed an extra this, or let's look at this machine, or let's look at this drug critically, right? Like I'm not saying add every billion-dollar drug onto the formulary and let everyone use it willy-nilly. But there's new drugs that are being created for right places, and clinicians should have those as tools. So I think the burnout and not feeling supported really was the bottom part of that. And then COVID happened. And then everybody in the ICU, I think, was burnt out because we were the only ones working. Everybody else was on furlough. So they're like, oh, yeah, you remember that committee or that report that needed to be, oh, well, you're the only one at the hospital, so you get to do it. So that being said, starting before COVID and then through that, and my husband already knew, he was the one that I would talk to all the time, and he knew the horror stories and he knew how tired I was and he knew how burnt out I was. So he'd already been saying, let's look at industry. Let's look at other positions for you that will make you happy. So I did. I just started calling some of the industry partners that I'd worked with in the past, doing either research or being a speaker for, because I believe in their product. And I just kind of called around. And so Cumberland, they had Vaprisol, Conivaptan. I did a majority of those hyponatremia in the ICU studies. So I'd worked with Cumberland a lot. And so they said, yeah, we'd love to bring you on as an MSL. I have always been pro-industry. I do think there's guardrails that need to happen. When I first started, pharmaceutical industry could take you out golfing and gets to take you to the spa and like there were no rules. And now I think we kind of swung back. Now you're like, oh, you can't even come into the hospital and we don't want
taboo, right? To even like be seen in public or to have any interaction at all. Yeah.
You're like Sunshine Act. No, you can't go to dinner, right? So all of those things, I do feel like it's kind of starting to swing back, I think, because all clinicians across the board are realizing that you can't do everything without industry partners. And partners, I think, is the way that it should be, right? So again, I've always been pro-industry, so it didn't feel icky to go to the dark side, so to speak. And again, I think whatever the products are that you have in your space, you just have to find out what that right niche is, right? It might not be first-line antibiotic for everything. It might not be the first-line treatment for everything, but it is a tool for clinicians to have in their tool belt in case it is the right time for that agent to be used. And I do think industry's making amazing leaps and bounds, right? Like, I remember when hepatitis was like deadly, right? Like, you died from hepatitis. Now it's curable. Like, I remember when HIV/AIDS was, oh, you were going to die. Like, and now people live forever undetectable with these new drugs, right? So there's amazing things that are coming out. CF, who has seen a CF child who had the right mutation to have the drugs? What? That's insane, the quality of life. So yeah, industry is making these leaps and bounds. It's just, I think now we need to figure out how to partner with leadership in the academic spaces, leaderships within the hospitals, insurance companies, right? Like all of these people need to come together, sit at the table, make it patient-centric. Obviously, everybody's in it for some money. I'm not sad about that, right? Like everybody needs to make money, but it needs to be somehow worked out so that it's equitable and that it makes sense.
Yeah.
An insurance company should not tell us, oh, you can't get that drug because it's too expensive, or you have to fail 4 other drugs that are lesser before they'll even consider it.
Yeah. Having worked on things now from both sides, I'm wondering if there's some lessons for us still on the clinical, particularly academic side, Craig, because it's academia really that has the difficulty with industry. It's not really the private practice medicine. What are some maybe misconceptions we have, or things that, if we only knew, we could be better partners for industry in moving research forward, et cetera?
I think the first is that your medical science liaisons with the company are not salespeople. We are there to tell you all the details about the drug that is there, the disease state, work with you then to do the research on the gaps. Where are the gaps? Like, where can this drug maybe be used in your space, right? How can we do that? For example, and that's what the MSLs are, right? They're not there. I don't get paid on, based on how much I sell or how much the company sells. Like, my job is medical. My job is to give it to you straight. My job is to tell you exactly like I would have on rounds, right? No, why are you using that? That's so stupid. Oh, great idea. I think we should do that. Should you partner with this? That's what we're all about. So I think you can learn a lot because the MSLs know everything about that disease state to the nth degree. They know everything about that product, and they know everything about that field, that space. You can learn a lot from somebody who has that in-depth of knowledge about 1 or 2 things in their therapeutic areas. So I say use them for that unbiased knowledge, right? And then work with those companies then to help you answer the areas of gaps.
Yeah. Where would you recommend someone get started to do that? Let's say I have an idea that I want to repurpose some drug that's been used in a different space, and I want to bring it into the neurocritical care unit, right? And look in my population, I've identified a drug company. Like, where would I even get started in making those connections and seeing what we could do?
It's a great question. So if you don't have a sales rep or an account manager that you're aware of or whatever, I would start with their website, right? And a lot of the websites for these pharmaceutical companies will have one of 2 things. They'll say, do you want someone to contact you from whatever? You put all of your information in and someone will get a hold of you, or you just call their medical affairs, right? Like, and then that person can direct you. I typically would probably start with someone in medical affairs, like a medical science liaison who's a boots on the ground. We're in the field. We can chat with you about it. The MSLs also understand what kind of money there is to support whatever the product is, right? So if it's coming to the end of the lifespan, there may be lesser monies, but we also can work with you. Maybe we have $10 to give you, but we can work with you on these other grants, right? Where we know, like a PCORI grant, we know that maybe they're giving some money away in this space also. So we can also help partner with these grants to help you, right? So the other thing is, once you get the money and the budget and whatever, that MSL, along with their medical support staff, also have a lot of things to help support you, right? So we'll have a statistician that we can give to you, right? we don't have to be involved ourselves, but we have a statistician that we're like, here you go. We will pay for the statistician. Oh, you need a red cap database and you don't have availability. Let us get you one. Oh, you want blah, blah, blah. Let us help you. Oh, you don't have time to write it. Let us write it, give it to you in a format that then you can. Sometimes it's easier for people, right? If they've got something written.
Absolutely. Yeah.
And then you go back in it and make it however you want, but at least an outline with some words starting on paper can be the hardest. So there's a lot of ways that we can partner that I think people don't think are available to them.
And I think that's really helpful because I think many of us in academic positions, it's very much, we're made aware of what the NIH can offer us and how to go through that process. And there's a lot of pressure for us to go through those avenues to get research dollars. But we know that there's limited NIH dollars for, as you mentioned, these rare diseases that we see all the time, like subarachnoid hemorrhage, and that maybe industry partners are perhaps more helpful in answering some of these questions that we have.
And I really think that these, I don't work for UCB Pharma, but, they are dedicated to the seizure neuro space, right? That's what they do. So if there's something in that space, like they would be a company that I would go to for seizures and be like, I would really like to work with you on this. Maybe it's with one of their drugs, maybe it's with a device, maybe it's with whatever. But these companies want the best for the patients also. So it needs to be within their realm, right? They're not going to go sponsor something that's outside of a therapeutic area that they are vested in, but yet it just kind of makes sense for pharmacy or for the pharmaceutical industry, all industry actually, not just pharmacy, but all industry to be partnering with clinicians.
Yeah. I wanted to finish up a little bit by bringing this back to the Curing Coma Campaign. You mentioned that sort of one of the goals of the Curing Coma Campaign is to bring everybody under one tent to solve the moonshot, including industry, academic medicine, and all of the constituents thereof. What's really exciting you right now about the Curing Coma Campaign and what's going on and where we're headed?
So I was a part of Curing Coma Campaign from the inception. Stefan Mayer and myself were the co-chairs of engagement, which was basically telling everybody what curing coma is. Like everyone's like, oh, that's so stupid. What is this? Like whatever. And, we're like, oh, well, about surviving sepsis and all about whatever. That's kind of what this is. So our Stefan and I's job was to start getting the word out to, first you have to get buy-in from the Neurocritical Care Society members, right? But then it's like, then you need to go out and get PEDS people. Then you need to go get the scientists. Then you need to go get industry. Then you got to go get the philanthropic population. And then you need those patients that have gone through the system, right? So it's like engagement was really just pulling all these people in. And then we had these big ideas, right? It was like, oh, we're going to have this whole data collection center and oh, we're going to have this whole research thing. And so watching it grow from the first neurocritical care meeting where I sat there literally with my iPhone and asked people if they knew what the Curing Coma Campaign was. And 99 of the people at the meeting didn't have a clue what it was, all the way till now, watching how we're choosing the data elements now that we're going to be collecting, right? And how we're going to be partnering with the foundation to get some money over there to help with some of these bigger projects all together, right? I want the scientists to feel excited to do some of these products, but then I want them then to infuse it down to the patient, right? Like I need the scientists to do this great research, but then I need them to connect it to a translational something, right? So that's what this umbrella hopefully will do, is bring all these people that are doing great work all over the place and connect them so that they all know what they're doing, when they're doing it, and how they can work through a longitudinal process.
No, that's very cool. I think we're all super optimistic and hopeful that we can use that umbrella to actually drive some of this comparative effectiveness research, going back to how we started this conversation, take advantage of all this variability that's out there, right? And then we can compare what's more effective in a better way. And then we can have better guidelines with actual recommendations. So I think you've solved all the problems of neurocritical care.
right, in 45 minutes. See?
Yeah.
Mic drop. No, I do. I am really excited about the Curing Coma campaign. And again, it's also getting members of the communities involved as well. Those parents that have had a child that had some head injury and they know what it is, what the issues can be, or the gaps in what we didn't know when we were treating their child, or the kid who had status epilepticus, right? These parents lost a child, but they might be willing to give $100 a year ongoing, right? Like people give to St. Jude because they might not have a kid that had cancer, or maybe the neighbor kid had cancer, but now they're like, yeah, we're going to give $19.99 a month, or Tunnel to Towers, right? Like there's all of these things that I think people are passionate about. And there's more people out there that have had some type of experience, whether it was themselves or a family member or a neighbor or whatever, that would be willing to give $19.99 a month, right? And all of that crowdsourcing and all of that, bringing it all together under the critical care or the Curing Coma campaign, then allows us to use it to help all of these pieces fit together.
Yeah, well, it's really awesome. It's really exciting, and I'm glad we have such passionate people working on it, like you and Stefan, who's my co-host here on the podcast. We finished the podcast by just asking a few kind of quick hit questions to learn a little bit more about our guests. What passions or hobbies do you have outside of neurocritical care? What do you do for fun?
Well, I scuba dive. I love scuba diving. I love hiking. I have 4 children, so they keep me very busy and poor. And I have a great husband that we travel a lot. So those are kind of my hobbies.
Recent favorite travel spot?
I'm in it right now, please.
Can we admit that you are fresh off a dive when you joined the podcast, which is
100%. I did a 2-tanker. It's beautiful. Saw some eel, huge loggerhead turtle. It was a good day.
Very cool. I wonder if you can just complete the following. My purpose is, these are the big ones.
My purpose is to be the best wife, the best mom, the best clinician, the best at whatever I have in front of me. I want to be the best at. That's my purpose.
I recharge by
Party.
art.
Yep. I love people. I'm an extrovert. I recharge when I get in front of people. Like there's some people that go to a conference and they're drained by the end, which we are because we're staying up late, we're getting up early, we're learning, we're talking, but I feel so invigorated after a conference.
That's great. I love
life. I love life. I love wine.
And I want to be remembered for
being kind.
All right. We'll let that be the final word. That's, I think, a lovely way to end the podcast. Thanks so much for joining us. I really enjoyed and learned a lot from this conversation. And I think I am very excited to see where the Curing Coma campaign is headed next. Thanks so much.
Thank you, Nick.
All right. Well, that has been the Neurocritical Care Society podcast, our Perspective series. Please like and subscribe. You can find the podcast wherever you get your podcasts, including the Neurocritical Care Society website. Thanks for joining us, and tune in next time.